Congratulations.
All right. Patrick Smith. Okay, welcome everyone to a really important session. Perhaps not as attractive as our keynote this morning on sex, but data, what could be more exciting than that? So our first speakers, we've got 4 speakers, 20 minutes each. They'll take the call about whether they're open for questions or not. Our first speaker, Grant Sarah and Patrick Gould. Grant Sarah is the director of Inform and has a fantastic track record at bringing data together, changing clinicians' behaviour, and then publishing that data. And he's also presenting with Patrick Gould from Mind Garden and with working with Grant as well. So let's please all welcome Grant.
Thank you. Thanks very much. And you know, I acknowledge Patrick as my co-author, but he's abandoned me to do the presentation alone up here. So
it's not on that computer. That's confusing.
It's not on that computer.
So if you advance with slides, it's on this computer.
Okay. Oh, I see what you mean. So.
Your presentation. Sorry, what's up on that screen?
Yep. So.
You need to use the clicker to make it move. Yes.
There's just far too much technology for an old baby boomer here.
Apologies.
So.
Just this one here.
Yep.
No,
It's not doing it. There we go.
We've got 200 or 300 international as well, so live streaming and recording. So hence it's a little bit more technology we have to wrestle with.
So I'll trust the technology and try and keep going. But just to start by acknowledging that we're meeting on Gadigal land and also the Camaragal people and the Gayamagal people on whose lands I work and live. Is that any better? I think the microphone's not for the room, is it?
Yeah,
it's
no,
for
it's for both.
It's for both?
I'll increase the
Okay.
volume.
And just also to acknowledge that we're looking at data from many thousands of people who've used New South Wales mental health services, and we do so with gratitude and respect. So, just obviously the last few years have been a reminder that vaccine-preventable illnesses remain a really important cause of illness and of death. We did some work a few years back where we looked at overall preventable hospitalisations in New South Wales mental health, in New South Wales health services, and we really found, that one of the notable findings in that was surprisingly high rates of vaccine-preventable illness amongst the other illnesses that we were looking at, and so that prompted us to do further study. Apologies, so I'll stop looking at this screen here because it's completely wrong. So if I go back, okay. So we wanted to do a study to look at focusing in on vaccine-preventable illness and to ask the question about what's the rate of vaccine-preventable illness in people who use mental health services in New South Wales. And not just to get the headline rate, but to try and focus in on the detail, to get a sense of how that differs for different groups of people and for different types of vaccine-preventable conditions and across the state. So the work is part of the Mental Health Living Longer project, which is a data linkage that New South Wales Health it does and that we are running to try and broadly look at understanding the interface between physical health and mental health problems and to help drive service improvement and policy change in New South Wales to help improve those issues. And in this data set, we're looking primarily at hospitalisation data and at our community data as well. The linkage has data on people from across the New South Wales population, not just people who use mental health services, so we can compare rates and pathways and outcomes. And so what we did in this work was we looked at all vaccine-preventable hospitalisations in New South Wales. And I'm just going to fast forward because there's no way I can read the numbers from this side of the room over there. We looked at, next, are you clicking that for me? Sorry, thanks. And we identified about 95,000 vaccine-preventable hospitalisations. Now, when we're talking about vaccine-preventable hospitalisations, this is what we're talking about. So admissions to a hospital with any of those 19 or so conditions listed there, broadly in three groups: hepatitis B, respiratory infections, including influenza and COVID, and a range of other things. The conditions listed in bold there really make up about 95 to 98% of that group. So they're really the major ones. Thankfully, a lot of those other ones are rare, at least as causes of hospitalisation. Then we, yeah, thank you. Then we calculated rates of admission per 100,000 per year and looked at comparing the rate in people who had use of our mental health services to the rest of the New South Wales population. So in this study, the mental health cohort are people either who've had contact with our public community mental health services or who've had a public or private hospital admission for a mental health care in the study period. So it's about 418,000 people in the mental health cohort. And then we compared the rate ratios, adjusting for age and sex and disadvantage. And here's broadly what we found. So in these slides, the blue is the rest of the New South Wales population. The orange bars are the rate in our mental health service users. And you can see on the left, you've got any vaccine-preventable hospitalisation. Then you've got those three main groups: respiratory, hepatitis, and other. And you can see that the other group is quite a small group. It's mainly shingles, and it makes up quite a small percentage. So just focusing on the other two groups, respiratory infections, flu and COVID and some pneumonias, and hepatitis, roughly equal in volume. And you can see, you don't need a complicated statistical analysis to see that the rates are much higher in the mental health service users in the orange bars. If we just do the crude rates, the crude comparison dividing one by the other, you get the light grey bars down there, so about a nearly threefold difference. But of course, mental health consumers are younger than the New South Wales population on average. And so once you adjust for age and other differences, the adjusted rate ratio is 3.2-fold. So 3.2 times more likely to have vaccine-preventable hospitalisations compared to other New South Wales residents. You can see it's present across all of those grey bars. So it's present in all of the groups, in respiratory infections, particularly high in hepatitis. But when we looked at all the individual diagnoses as well, all the individual conditions, pneumococcal pneumonia and so on, it really was increased across the board to roughly equivalent degree. So focusing further, one finding that's, I think, not commented on a lot in a lot of this kind of epi research, but is a consistent finding in a lot of our data, is it's not just about higher rates, but it's about younger age. It's about earlier onset of a range of conditions. And so we found that particularly the risks were high in mental health service users in their 30s, 40s and 50s. So what you're seeing here is the average age at admission. The orange dot is the average age in mental health service users, the blue in the rest of the population. And you can see, with almost no exceptions, that mental health service users were much younger when admitted. So the average was about 9 years younger, and particularly younger for respiratory infections, so between 9 and 13 years younger at admission. Another way of looking at that is this, where we're comparing the rates in individual age groups. So you can see here, you've got males on top, females on the bottom, population in blue on the left, mental health service users on the right. And you've got the rate in each of those age and gender groups. And you can see that if you look at the blue side, mostly vaccine-preventable hospitalisations are relatively uncommon in people under 50 or 60, and then increase steeply later in life, particularly in the 70s and 80s. And a lot of that is about influenza. If you look at the orange side, you can see those graphs bulge in a different way, and particularly in people in their 30s, 40s, 50s, and that's reflected in the rate ratios for each individual cohort, which are the grey bars on the very far left. So particularly for men aged 35 to 65, they were about sixfold more likely to have vaccine-preventable hospitalisations, and women in their 40s and 50s about fourfold. So beneath those rates, there really is significant impact for the people involved, for their families, for the health system. And just showing you those rates kind of understates that slightly, because there's a kind of compounding effect here. So we found that The chances of an individual having at least one vaccine-preventable hospitalisation in a mental health cohort was 6%. So people had a 6% chance of having at least one admission in the study period, compared to 1.5% for the rest of the population. But mental health service users were more likely to have more than one, so they had an average of 1.7 admissions per person. And when they're admitted, they stayed longer as well, staying 8.2 days rather than 7 days. And so the kind of cumulative effect of that for those people was that in this, the way this is defined here, that the mental health service users made up about 3% of the population, but they experienced 12% of the vaccine-preventable hospitalisations and about 13% of the vaccine-preventable bed days. The other thing that we're trying to do with this data is develop detailed local data to help kind of prompt and guide and support change efforts by local health districts. And so this is showing you the rates for local health districts. Each one of the rows here is one local health district. I haven't identified them here, but we report it back to them in an identified way. And the blue dot is the rate in the population. So you can see there's a quite a variation across New South Wales, more than a twofold variation in the vaccine-preventable hospitalisations at the population level. And it's mainly the metropolitan areas, particularly the inner city areas towards the top, and the rural and remote areas towards the bottom. So higher rates in the city. If we look at our mental health consumers as the orange dot, and that grey bar is the gap in between the two, and you can see that across the state there is a gap in all LHDs, and even though in absolute numbers there's much lower rates in mental health service users in some of those rural LHDs, proportionate to their population rates, it's still a very substantial gap. That gap varied from about 2.5-fold to nearly 4-fold. And so this is trying to provide the data to services in a way that they can make use of, and we'll talk more about that on Thursday. So just to finish up quickly, then it is important, I think, in looking at this data to recognise that there's just not a simple linear relationship between vaccination and vaccine-preventable hospitalisations. That the answer to this isn't, if only everyone was vaccinated, that would, close that gap. There's likely to be many interacting factors, and we've learned, a lot more about that collectively through COVID. And of course, those factors are likely to be different for different people, different conditions, and different places. But it's quite likely that some of those factors will include potentially the mental health service users in some settings might be more exposed to vaccine-preventable illnesses. They might have lower vaccination rates. They might, despite being vaccinated, be more likely to become ill. There is some evidence of less effective vaccination related to a range of mental and stress-related factors. There's also likely to be an impact of other conditions on severity of illness, and that's certainly, we know that's been a big factor in COVID. People who have comorbidities, who have respiratory conditions or heart conditions, much more likely to get more severe illness and need hospitalisation. And also, it's not just severity of illness that drives hospitalisation. It's your resources, it's your supports, it's your living situation. And so there might be an interaction across all of those fields. Understanding how those interact and how they interact differently in different groups is clearly important to try and help prevent some of this. And certainly there's more work that we're seeking to do, and Patrick is in the process of doing to further explore some of this. So, and particularly with that, in the current linkage that we're about to do, we're adding in data on vaccination rates through the Australian Immunisation Register and the Notifiable Conditions Information Monitoring System to look at rates of those conditions, influenza and COVID in particular. So we can try and tease out some of those interactions and how those things combine. There's clearly a need to identify and support models which support access to vaccination, and Patrick will be talking a bit later, unfortunately in another room, on some models that South East Sydney have been implementing to do exactly that. There's probably also things we can do at the policy level. There's clearly some policy barriers and financial barriers, and to being able to access vaccines. So the data could be hopefully a prompt for change. And as I've mentioned, we're trying to develop local reporting to help support and prompt action by local health districts. So really, I'll stop there. I just wanted to acknowledge and thank the collaborators and people involved in the Mental Health Living Longer project. I've listed some of the names there, but particularly to acknowledge and thank Fred and Jen from our team, and Wendy, who's not here in the room with us, and Patrick, who've been involved in helping them work and do this work. So thank you very much, and I'm happy to take questions if time allows.
Yeah, we've got time for one question from first in.
John,
Right, thanks very much for the work. Is there any comparable work for different other compromised groups like social disadvantage or people compare in this?
Look, it's a very good question. I'm looking back towards you there, Patrick, to see if you might know anything. I can't think of anything. I know certainly in some of the other kind of primary and preventative work, for example, cancer screening, there's good work to that. And what we see is that the gaps in mental health service users are actually even greater than the gaps in Aboriginal people or in women from culturally and linguistically diverse backgrounds in, for example, cervical screening. So I suspect if we had comparable data, it would tell us a pretty sad story. Yeah. But I don't know if anyone else knows if there is comparable data. Thanks, Patrick. Fantastic.
Actually, I failed as a chair. I've actually got a few more minutes, so there's time for another question or so.
Okay.
My only job is to start and finish on time, and you're so great, Grant, so much of your details so quickly. But any other?
Did I understand that you don't know the vaccination rates for that population?
That's right. In this data set, we don't. All we know is the hospitalisation. So the next linkage will include the vaccination, so we can look at that.
I've got a question.
Yes.
I mean, one of the exciting things about the work you do is the engagement with service directors, etc. Tell me how about that interaction, how they're responding to the data, in terms of changes in practice, and maybe how the branch is responding in terms of changes in KPIs.
Yeah, look, I think in general, people love to see data, and I think it's one of the reasons it's a useful kind of lever and tool for change. So certainly, I mean, to me, there's two groups that have been very engaged with this data. So certainly the local health district clinical leaders have been very interested. A number of local health districts have been engaged with trying to implement improvement efforts. The other group that have been very interested and engaged has been the policymakers. So New South Wales Health is currently doing some work to update its overall vaccination plan, and certainly the population health, public health colleagues have been really interested in this and used it to kind of prioritise and really identify mental health as a priority issue and cohort within the overall vaccination strategy. So yeah, I think there's an appetite for the data.
One more question.
Has there been a response, a practical response from that particular data?
Yeah, definitely there are individual projects and improvement projects happening in a number of LHDs, and there has been an inclusion of a commitment to trying to support this within New South Wales policy. I think there's more we could do, and certainly, for example, at the national level, through the college or otherwise, some of the financial barriers to subsidised vaccination for flu, for shingles, for various things, and is another area we could kind of think to try and use this data to push a little bit more on.
Okay, well, I just once again you'll have an opportunity to see a lot more of Grant's work through the conference, and you see that the quality of that it's just astounding to me, like the quality to data linkage, the links to health services, quality improvement, and also the international publications and impact that's having. It's really world leading. So, and I think the other thing that you pointed out was around the age of onset as well, with some really new insights. So I'd like us all to join and thank Grant.
Thanks, Mark.
Now, when we talked a little bit about age of onset, I think this next piece of work is very exciting. It might be preemptive, creating a forward momentum, but I think it's an exciting piece of work in terms of national data feasibility, but also starting to explore the issue about predicting age of onset. Hopefully that's okay, Maggie. So our next presenter is Maggie Lee. She's a lecturer in the department from Macquarie Uni and a PhD candidate, but she's doing a large project with the Department of Health Informatics, Data and Informatics branch. I never quite get that right, which is a massive data linkage project. So I'm very excited to see where we're up to with that. So let's all welcome Maggie Lee. Hopefully that's you. May have to go.
Well, it's not going to the stream yet, so it'll actually be this computer here. If you just bear with me a moment. Sorry.
Oh, do I wait for you? Okay,
It'll just be this computer here. Just bear with me a moment. Sorry.
that's all right.
We're having some technical difficulties. Slowly but surely. Sorry about this.
It always happens. It's all good.
This sounds right as well while I'm here. Okay. Come on. Okay. This is you. Okay. Should we continue now? Sorry about that.
That's
If
all
the
right.
clicker's not working, you can advance with this button.
Okay, I think it's all good. All right, thanks a lot, Russell. So hi everyone. I'm a PhD candidate at the ANU, and my current project, I'm working with the Department of Health and Aged Care under a project that's called the Healthy Minds, Healthy Bodies. So today what I'll be talking about is the research under that project, which is the mortality analysis of mental health cohorts with comorbid physical conditions in Australia. Okay, so in terms of the agenda, I'll first go through the context, then also just go through briefly some similarities of the Healthy Minds, Healthy Bodies project with a similar project that we're aware of by Equally Well as well. And then lastly, the preliminary results that we're seeing for the life expectancy gaps to date. Okay, so in terms of context, improving the physical health and life expectancy for people living with mental health conditions is a focus area for two government arrangements, one being the National Mental Health and Suicide Prevention Agreement and the other being the 5th National Mental Health and Suicide Prevention Plan. So what we hope to do under the analysis for the Healthy Minds, Healthy Bodies project is essentially to contribute to the evidence base for these two government arrangements. So the work to date that has been done has been focused on the first objective of the Healthy Minds, Healthy Bodies project, and that is trying to answer the question, what are the health and social outcomes of individuals that have comorbid mental and physical health issues for different diagnosis groups compared to those without such conditions? Now, in order to get a better understanding of the health and social outcomes, one of the first aims of the study is to look at quantifying the life expectancy gap of individuals in Australia, as well as the factors including their physical comorbidities. The other is then identifying the risk factors for these cohorts. So that might include factors such as smoking, diet, physical activity, or alcohol consumption. And then lastly, we also hope to identify preventable hospitalizations and hospital readmissions for both mental and physical health issues. Now, we are still in the early days, so what I'll be going through in terms of our preliminary results is really focused on the first part, which is looking at the quantifying the life expectancy gap and everything around the excess mortality that we're seeing. Okay, so in terms of the comparison between the Healthy Minds, Healthy Bodies project and a similar Equally Well project, we know that there's also one going on at the moment. Both are aligned to the two government arrangements that I've mentioned already. They are similar in terms of the type of analysis. So we're both looking at the life expectancy and life expectancy gap and risk factor analysis, which is really great because we can make sure that we're aligned in terms of the findings that we're getting on a national basis. But what we're hoping to do for the Healthy Minds, Healthy Bodies project is to extend it and hopefully eventually look at the excess mortality experience by different mental health cohorts or different diagnosis groups. Now, in comparison, the Equally Well analysis really is on an aggregate basis, but what's really good about the Equally Well project that's going on at the moment is that it's able to do a time series analysis to what was done by the ABS in 2017 on 2011 experience. Okay, so in terms of the data that we're looking at, we have two large linked data sets. One is AIHW's National Integrated Health Services Information Analysis Asset, so that's NICI-AA, and the other is ABS's Multi-Agency Data Integration Project, so that's MADIP. In terms of the timelines, so for NICI-AA, the data that we have at the moment is a little bit older, but we're waiting for a refresh. It ranges between July 2010 to June 2017 and includes hospitalisation, Medicare benefit schedule, pharmaceutical benefit scheme, residential aged care, and the National Death Index data. For MADIP, we have similar data, so we have MBS, PBS, National Death Index, but we also have census and demographics data, migration, survey data that includes the National Health Survey and Survey of Disability, Ageing and Carers, and income and taxation data. So in terms of the data sets, the ones that are highlighted in teal, those are unique across the two. And so what we see is if we're doing a mortality analysis, it's quite important to get the exposure right. And so we're focusing on using NICI-AA first because the advantage of that is we can use the hospitalisation data. But as we move towards analysis on risk factors and so forth, we see the second data set MADIP to be very good in supplementing that information because we will get more information on the demographics, migration, the survey data, and income and taxation and so forth. Okay, so those are the two data sets that we're focusing on. Okay, so in terms of methods, we're proposing a population-based cohort study. At the moment, it's split into two cohorts, one that we've defined as a broad mental health cohort, so that has a wider spectrum of mental health conditions, and the other we're defining as a severe mental illness cohort. We do plan on then moving on to further segmentations by diagnosis groups later on. So in terms of the metrics, we're proposing a harmonised panel of mortality metrics. This was a call by earlier Denmark researchers that published in the Lancet that said that there is a need for, I guess, consistent metrics to allow for comparisons and within nations as well as by groups. So we are continuing with that harmonised panel of mortality metrics, those being the mortality rate ratio, the life expectancy metric, as well as the life years lost metric. And then we also propose to add one additional metric, which is the health expectancy metric. So I'll go through all of them in terms of the advantages and disadvantages. So the mortality rate ratio metric, as all of you probably know, is a very popular metric, and it's used in pretty much most of the studies on mortality. The disadvantage of this is it is a relative risk measure. So when we say someone is 3 times more likely to die than someone else, what exactly does that mean, right? When everyone's going to die eventually anyway. So whilst it's a comparison of mortality experience, there is that disadvantage of being not easily understandable by policymakers or the general public in general. Then we move on to life expectancy and the life expectancy gap metric. Now this is more easily understandable. If we say females are 5 years, on average live 5 years longer than males, that's an absolute risk measure that's probably more understandable by policymakers as well as the general Australian population. But the disadvantage when we apply it to the mental health cohort is that it doesn't take into account age of onset. So if we look at previous research that has looked at this metric, which is around the 2010-2015 kind of time frame, they tended to use the life expectancy metric, but what they had to do was make an underlying assumption that everyone in the mental health cohort had an age of onset of 15. Now, clearly that's a limitation because not everyone has an age of onset of 15. In fact, what's been suggested is that's often led to an overestimation of the life expectancy gap. So then we move on to the life years lost metric. Now, this is a more novel approach, which does now take into account the age of onset of the mental health condition. Now, because we're moving on to dealing with age of onset, our definition, therefore, is we need to make an underlying assumption that everyone in this cohort has an enduring mental health condition. So in our case, we're only looking at the severe mental illness cohort for this analysis. Now, what we're essentially doing is we're following someone who is born. We look at if they're identified as being part of the severe mental illness cohort, what their age of onset might be. So that might be age 15, for example. And then we estimate their future life expectancy. From there, we compare to the general Australian population who was not part of the severe mental illness cohort. Again, go to age 15, estimate their life expectancy, take the difference. That is what we call the excess life years lost. Now, that's for only one age of onset, so age 15, but we can do that for every age of onset from 0 to, say, 95. So from there, we then take the age of onset distribution and then weight that to get one single metric, which is what we call the weighted average excess life years lost, and then that takes into account the whole, all the ages of onset, which is the advantage of this method compared to the life expectancy metric, and it's also still an absolute risk measure. And then lastly, health expectancy. We've added this in because all the other metrics are all about the quantity of life. We do also see it's important when we're looking at this cohort to also understand the quality of life. And so that part, we're trying to add that perspective here in this study. Okay, so in terms of our preliminary results, for our mortality rate ratio, what we're seeing is for the broad mental health cohort, they are 1.6 times more likely to die than the general population, and we also have split this by female and males. When we move on to the severe mental illness cohort, what we are seeing here is they are 3.9 times more likely to die than the general population. And again, we have the split by females and males here as well. Okay, this next slide here is on the age-specific mortality rates. So if you look at the graph on the right, what we have is we have the splits by the cohorts. The solid lines, blue and red, are for the severe mental illness cohort split by gender. The larger dotted lines are the age-specific mortality rates for the broad mental health cohort, again split by gender, and then the smaller dotted line is the general Australian population, again split by gender. So what we essentially see here is for every age, we're actually seeing that the severe mental illness cohort has a higher mortality rate at all ages compared to the broad mental health cohort. And then when we compare the broad mental health cohort at every age, they also have a higher mortality rate experience compared to the general Australian population. Okay, if we then move on to the life expectancy and life expectancy gap table, how you should interpret this table is if we look at the ages, the way you should read it is what is the life expectancy and therefore the life expectancy gap if we assumed that everyone in that particular cohort had an age of onset of whatever. So I've only taken out some. So if they all had an age of onset of 0, 15, 45, 65, or 85 plus. And I also have it by males and females. So if we just focus on age 15, for example, which is what would be the results in the research papers in 2010 to 2015, what we are finding is for males, they have a 9.4-year life expectancy gap for the broad mental health cohort compared to the general population. And what we're seeing for females is they have a 7.5-year life expectancy gap compared to the general population. If we move on to the severe mental illness cohort, what we're seeing is males have a 20-year life expectancy gap compared to the general population. And for females, it's 19.3 years compared to the general population. Now, this is broadly consistent with what we're seeing in those previous studies and also on other national studies as well. Now, what's also interesting to note is in all the cohorts, the general Australian population, the broad mental health cohort, and the severe mental illness cohort, females still are expected to live longer than males. Okay, so that's just something to note there. Okay, so for this next graph, this is on health expectancy. So this graph shows the proportion of remaining life spent in the disease state, whether it's the broad mental health state or the severe mental illness state at each age. So if we look at the dotted lines again, and we look at the red line, this is for females, and it's saying the proportion of remaining life spent in the broad mental health state at each age. So females are expected to spend 27% of their remaining life at age 0 in the broad mental health state, and this is predicted to increase to 44% past age 80. For males, they are expected to spend 19% of their remaining life in the broad mental health state at age 0, and that's expected to increase to 31% past age 80. If we then move on to the severe mental illness cohort, what we are seeing is for females, they are expected to spend close to 0% of their remaining life in the severe mental illness state, which is severe mental illness state at age 0, and then that's expected to increase to 7% past age 80. For males, what we have is they're expected to spend close to 0% of their remaining life in the severe mental illness state at age 0, and that's expected to increase to 5% past age 80. So what's interesting here is we're seeing that females are expected to spend a greater proportion of their remaining life in whichever the broad mental health state or the severe mental illness state. But if you remember from the previous slide, which I can't seem to go back, but if you remember from the previous slide, females generally have a longer life expectancy. So they are spending more of their life in this disease state. So this is kind of more an indication of the quality of life. Okay, so the next one here is on the life years lost. These two graphs here are on the survival curves of someone who is age 15 in the severe mental illness cohort. So that's the graphs on the left. And then someone who's age 45 in the severe mental illness cohort, those are the graphs on the right. So this survival curve, normally if we're looking at life expectancy, that's the white area underneath the survival curve. When we look at life is lost, it becomes the area on the top, which is the purple plus the green area added together. So for the life is lost, what we're seeing for someone who is in the severe mental illness cohort at age 15, they're expected to have more of their life is lost contributed by external causes of death than compared to someone who's age 45, which I guess is not surprising. If we look at the breakdown, what we're seeing is those external causes of death are primarily intentional self-harm and accidents. But what we also see, though, is in terms of the greatest primary causes of death, they are still the physical conditions. So that includes the yellow area, which is neoplasms, followed by circulatory system diseases, so that's the bottom teal colour. And then the third largest would be the nervous system diseases. So this is only on life years lost. We then move on to excess life years lost, which is when we compare it to the general Australian population. So the graph at the top here is when we compare to the general population. I've taken again some of the ages, so age 15 onset, 25, 45, 65, and 85. And what we can see is for the excess life years lost, we're seeing a greater proportion from the external causes at the younger ages, but that tapers off as we move to the older ages. Now, in terms of then the breakdown, the graph on the right has the more specific primary causes of death, and you can see, again, for the excess life years lost, for the external causes of death, they're essentially intentional self-harm and accidents, but the largest one here is still neoplasms. You can see that in the large blue line, okay? So after we've done that, then we've got an age of onset as well, and we can weight that. So we weight all of these findings into one single number, and what we're finding is a total average excess life years lost of the severe mental illness cohort to be 12.06 years. And that can be split into 10.1 years internal causes and 1.95 years external causes. Okay, and again, for the table on the right, that's just a more granular split. And so the greatest contributor is very much a physical condition, which is neoplasms, of 6.24 years. Now, you might be wondering why there's so many other numbers. This is really just a sensitivity test. So our age of onset distribution is dependent on our follow-up period. So we've just changed our follow-up periods by a little bit just to see how different our age of onset distribution does become. And the good thing is it doesn't change very much. It's not actually a very variable number. So that's a good result. Okay, so those are our preliminary results that we're seeing. Okay, so just because I'm running out of time, in summary, this is essentially just saying that our results are quite consistent with other national studies. And in terms of future work, we do plan to split by different diagnosis groups. We are also still searching for the most accurate and practical excess mortality measures, and we still plan on doing the risk factor analysis, which will give us more insight into the association between mental health conditions and physical health conditions, as well as risk stratification tools to help inform preventable hospitalizations and hospital readmissions. Okay, so that's basically it. I guess I'll open up to any questions now.
We've got just time just for one question. Scott.
Thanks. Great presentation, and just I think you've really explained well the complexity of the questions you're trying to answer and done a good job of it. I'm just curious, how are you differentiating the two groups, broad versus SMI?
Yeah, that's a really good question. So at the moment, what we're doing for the broad mental health cohort is we're taking the same definition as AI, HW's mental health cohort, which is just anyone who is using mental health services that can be captured in MBS, anyone who's taking mental health related drugs in PBS, and anyone who has a disorder from F00 to F90 as a primary diagnosis code in hospitalizations. So that's the broad, that's capturing everyone. When we move on to the severe mental illness cohort, what we're trying to capture are the people who are bipolar, schizophrenia, and we also recognize we should also include severe depression and severe anxiety, but that's still a work in progress. For bipolar and schizophrenia, we use those diagnosis codes in hospitalization. And then for MBS and PBS, we've relied on mental health experts to give us a rule-based definition using certain medicines, as well as seeing psychiatrists how often. So that's probably like once every quarter, that kind of definition to get the severe mental illness cohort. But it is still a work in progress. Yeah.
Okay, it's a fascinating project, and the wealth of that data linkage is really the envy of the world. There's very few other countries that have got that capacity to bring data from so many sources. So great opportunity to influence policy and practice in Australia and internationally. So can we please thank Maggie?
Thank you.
just a bit of cross promotion as the AV guys are doing. Sorry, it's a little bit clunky going around, but we are live streaming this. Dr. Alfred Wong is presenting, I think, tomorrow on the other aspect of this, the data linkage project, which is where we're trying to track how we're going in Australia over 5-year periods. And he's going to present some of the preliminary results around that. What's that? First, yeah, exactly. So our next speaker is Sahela Ali from University of Queensland, and she's working in the Queensland Centre for Mental Health at the moment. She's doing a PhD in this area. She's got lived experience of bipolar, and she originally started working in, what's your first research?
Neuroscience.
Neuroscience.
Yeah.
Now she's looking at sort of unpacking some of the complex aspects and some of the systems approach to this complex way. Her description and CV is on the program here, and hopefully we might see some more of Sahela later in this conference. So let's all welcome Sahela.
All right. So, is this?
Point it down at the computer.
Oh.
Rather than pointing it at the screen.
Okay, perfect. So today I'll be presenting the final study of my PhD, my PhD has focused on premature mortality in people with severe mental disorders, and this study is looking specifically at people with schizophrenia. So I'd like to start off by acknowledging the traditional owners of the land on which we meet today, the Gadigal people of the Eora Nation, and I recognize that sovereignty was never ceded, and pay my respects to elders past and present, and extend that respect to any First Nations people watching the presentation today. So to start off just with a brief bit of background, it's well established that people with schizophrenia die significantly earlier than the general population, and most of these deaths are due to potentially preventable physical diseases. And we've known about this mortality gap for decades, and it has not improved over time. And we have a general understanding of why it exists. There are numerous factors involved. There's increased prevalence of behavioral risk factors like smoking. There's factors related to health systems that affect provision of healthcare. And of course, there's the contribution of social determinants of health. However, a holistic understanding of this problem and the underlying mechanisms is still lacking. And there is inherent complexity involved with a range of factors operating at these different levels and interacting with each other. And these interactions are not really captured in tables and lists like this, which are examples of linear thinking, displaying factors as independent and equally important with sort of direct causal pathways. So to better understand the complexity of this problem, we can use an approach called systems thinking. So I'm going to provide a bit of background about that because some people might not be familiar with this methodology. But basically, we can think of a system as a collection of interconnected parts that are organized in a way that achieves something, so it has a particular function. And systems thinking is an approach that looks at how the component parts interact to produce particular behaviors or observable events over time. And applying systems perspective allows us to look at the big picture and can help us identify root causes of complex problems. And by understanding the structure of a system, which is the source of its behavior, we can identify ways to restructure it to produce better outcomes. So premature mortality in people with schizophrenia has primarily been framed in sort of traditional epidemiological terms, with a focus on assessing the relationship between independent variables and outcomes of interest. So to better understand why the mortality gap is not improving, we can conceptualize this issue as a complex system to explore the interactions between these factors rather than examining them in isolation. So after defining the problem to explore, the next step in systems thinking is called causal loop modeling. So this involves developing a conceptual model of the problem known as a causal loop diagram, or CLD. And this is a tool which enables empirical research and theoretical knowledge to be combined into a visual representation of causal relationships. And the variables in a system are usually the easiest to notice because they're often tangible things that we can measure. But in terms of actually changing system behavior, it's actually the relationships between the variables that are often more important. And when the effect of a variable can be traced back to that original variable, this creates a feedback loop. And feedback loops are really the mechanisms that create the behaviors of a system that persist over time. In terms of how CLDs can be created, they can be created using primary data such as interviews or secondary data from literature reviews, and they can be created collectively with a group of stakeholders in a process called group model building, or created just by researchers, which is what I did. I'll talk about the specific methods I use in the next slide. And in terms of why they're useful, they provide a conceptual framework that allows us to test assumptions about underlying mechanisms, interpret existing evidence, identify areas where we can potentially intervene, as well as those that are in need of further research. And it's particularly important to keep in mind that these models are simplifications of the real world, and we choose how much complexity to look at. And they can be continually updated as new information emerges and with input from different stakeholders. So in terms of the methods, the first step in causal loop modeling is defining the boundaries of the model. So my focus here was on what happens after a person develops schizophrenia and the subsequent pathways that lead to poor physical health and premature mortality in order to identify potentially modifiable factors. So this excluded biological factors and early life exposures that can contribute to both schizophrenia and physical diseases. I constructed the CLD using published literature that I identified through a previous systematic review from my PhD. And first I looked at systematic reviews and meta-analyses to identify well-established relationships. And then I used single studies to dive into like more specific variables and relationships, as well as narrative reviews to examine relationships that appear important but where empirical evidence is still lacking. I also included both quantitative and qualitative evidence. And I just want to reiterate that this approach is very purposefully different from traditional sort of epi approaches in terms of being much more inclusive. So we didn't really apply restrictions or grades to the evidence because we really wanted to capture the complexity of this problem, which operates across different domains and includes some relationships that aren't so easy to quantify. I constructed it using this free online platform called Kumu, and the relationships, the variables and connections were iteratively reviewed and refined. And in the process of trying to identify those feedback loops, we did add in some hypothetical connections, which again reflect areas that would need further research. Finally, we did hold a consultation with several experts with relevant research or clinical experience to get their feedback, which was used to refine the CLD. So now there's a video, which I hope will work, which will provide a walkthrough of this interactive online platform. So I think that's playing. Yeah. So it begins by introducing what a CLD is, why it was developed, and then it leads into this like little presentation that explains how you navigate this platform. So it provides a bit of background on systems thinking, and then it moved into this subsystem diagram. So this provides a simplified, high-level overview of the system that results in premature mortality from comorbid physical diseases in people with schizophrenia. So it's useful to understand the sort of overall scope and boundaries of the model. Next, the variables are explained. So schizophrenia is positioned as the exposure, ultimately leading to premature mortality as the outcome, and all the mediating variables are classified into these three domains. So there are individual level factors, which includes factors related to physical health or health-related behaviors. Then there are healthcare factors related to health systems and services. And finally, there are social determinants of health. And then this shows how that you can click on a variable to see its definition, and there's also relevant time trends that I've added in. And here it shows how you can highlight a variable and see all of its sort of immediate connections. And next, the connections are explained. So in CLDs, you have positive and negative connections. So a positive connection, indicated by a plus sign, indicates that a change in a variable causes a change in the variable it connects to in the same direction. So for example, an increase would cause a corresponding increase. And then the negative connections, which are indicated by the negative sign, the opposite. So the change in a variable causes a change in the variable it connects to in the opposite direction. So for example, an increase would cause a corresponding decrease. And you can also click on a connection to see the evidence that it's based on, with tags indicating the type of evidence. And then there's the style and thickness of lines actually correspond to the amount of evidence that a particular connection is based on. So there are dashed lines that indicate a connection is hypothesized or based on a narrative review. The thinner lines correspond to a single study. The sort of medium lines are multiple studies, and then finally the thickest lines are based on systematic reviews or meta-analyses or relationships that are sort of just readily apparent or readily established. And then finally, we have the feedback loops. So this is a really fundamental part of this diagram. And there are two types of feedback loops. There are reinforcing loops, where changes in variables are reinforced, or balancing loops, where equilibrium is maintained. And you can click on the name of a loop to read its description. So in the example shown here, stigma from health professionals reduces quality of care, leading to treatments not being offered to patients who then develop acute issues, which then reinforces stigma. So loops can occur entirely within one of those three domains or across domains, as shown here. And then you're free to explore the diagram, and reminded that the CLD itself is an exploratory exercise. We're trying to figure out which factors are important, where we could intervene, what we don't know enough about, and what other directions we should be looking in. So I included a total of 74 references in that diagram for the supporting evidence for the variables and connections, encompassing a range of study types. There were a total of 21 variables, and, oops, sorry, clicked far too many times. 21 variables, 68 connections, with stigma and social support having the most connections. And there were a total of 23 distinct feedback loops, encompassing 19 reinforcing and 4 balancing loops. And the majority of these operated across domains, as well as 5 entirely within the social domain, 2 within the individual, and 1 within the healthcare domain. And unemployment was involved in the greatest number of loops. So I'm not going to go through each feedback loop. That would be too time consuming. So I'm just going to discuss the main sort of themes that I found. So one of the main findings was really the importance of social determinants of health. In particular, the feedback loops demonstrated the interconnected nature of social determinants and how they reinforce each other, making it difficult for someone experiencing social disadvantage to improve their circumstances without external changes, that is, shifts in public policy and social norms. We also only found 2 individual level loops. The rest involved healthcare or social domains. And this is important because the onus is often put on the individual, particularly in terms of health behaviors. So this model really demonstrates how we can't ignore a person's experiences in the health system and the social context in which they live. Another interesting finding was about metabolic abnormalities. So metabolic abnormalities from antipsychotics are frequently pointed to as a contributing factor for premature mortality, but that kind of contrasts with the fact that overall antipsychotics are protective of mortality. And this CLD showed that metabolic abnormalities didn't play a major role in the system. So, of course, they do contribute to the development of physical diseases, but in terms of system behavior, the main contribution was actually reducing medication adherence. So addressing these side effects or effects would therefore not only reduce the risk of comorbidities, it would actually increase medication adherence and then obviously the protective effects of antipsychotics. Another finding was that stigma really had a central role in the healthcare system, really demonstrating the importance of relationships between health professionals and people with mental disorders. I'll discuss a few of the implications in the next slide. A few strengths and limitations. So one of the strengths of systems thinking is the ability to incorporate different types of evidence. So research in this topic has really been dominated by quantitative studies and a lot of perspectives from psychiatrists. And in this CLD, we incorporated qualitative evidence, including studies looking at the lived experience of patients, which is often overlooked in this space. And as I mentioned earlier, the CLD can be continually revised and even contextualized to specific countries and health systems and with input from different stakeholders as well. In terms of some limitations, I did use some studies that looked at different types of severe mental disorders together, and some disorders have different magnitudes of association with particular risk factors, for example. I also used some cross-sectional studies which are not able to show the direction of causality, so further evidence would be needed to substantiate those associations. And there were some of those connections that were hypothesized or based on narrative reviews. So again, this is only suggestive of causal relationships and points towards research gaps with empirical studies needed to verify these. In terms of future research, the next phase in the systems thinking methodology is dynamic modeling. So this involves developing a quantitative simulation model where you can collect detailed data to set values for the particular variables and relationships, and then you can use this to simulate the impact of different policies and interventions over time. And we really also need more empirical research on social determinants, as a lot of the connections related to those factors were based on either single studies or narrative reviews. Finally, in terms of the implications and significance of this model, one of, as I said, stigma was a major factor, so it's really important to be improving the relationships between health professionals and people with severe mental disorders. So this could be facilitated through shared decision-making and person-centered care, which can help build trust and make patients feel respected and empowered to take care of their own physical health. And this can lead to better self-management, which can help prevent diseases, as well as better continuity of care. So instead of, for example, visiting a GP for severe concerns, regular monitoring would be able to detect risk factors and diseases early. And of course, these are principles that are already reflected in the Equally Well consensus statement. And we do, of course, need to look beyond actions centered in the healthcare system, because one of the key findings was around the importance of social determinants. So this is where we really need holistic and integrated models of care that not only address clinical needs, but also practical, social, and financial needs. So in the UK, there's a mental health charity called Rethink Mental Illness, and they released this really excellent report on community care. So it describes how good quality clinical support is only the first step on a ladder to recovery, and the need to go beyond the health sector for people to thrive and not just survive. Of course, if we were to implement a comprehensive model of community care like this, we still need to look at the broader policy context. So for example, unstable housing was one of the factors included in the CLD, and we're looking at this current housing crisis that we're in. We need policies that are in the public interest. We need, for example, we need to frame housing as a public infrastructure rather than an investment. So overall, we need actions within the health system as well as at the government level across sectors in order to ultimately reshape the system to produce better outcomes for people with schizophrenia and other severe mental disorders. So I'm not sure if I have much time for questions.
Maybe time for one quick question. John.
Would you just mind?
Thank you very much. Fantastic.
Keep talking.
Keep talking.
just, you've got so much stuff there, I know it's hard to do, but what was the one thing that you found that really surprised you, or that we didn't think of before?
I mean, to be honest, this is a lot of stuff that we already know, but it's just like the benefit of systems thinking is really to see how everything is so interconnected. And yeah, I think I mentioned unemployment was involved in the most feedback loops, and I feel like we often forget about the importance of these really fundamental factors. So yeah, I think that's
I'm just, I was reflecting on that. How many times I've written in, say that in published papers, the phrases or the words, the relationship is dynamic, complex, and reciprocal. And the first time I read, and you're quantifying them, and you're describing them. So I think this is incredibly exciting in terms of that. And I know some of the work that Albert's working on shows unemployment not being employed. It's like the rate of premature death goes to 6 to 8 times that, and so really what you're doing is unpacking that even more. So I think this is very exciting in terms of a different way of approaching data and consolidating down. So thank you so much. Can you all join with me and thank our next speaker is from sunny Queensland. Here she is, Bella Malhotra. And she is doing a Master's of Medical Science at Griffith University. I see a sponsor mentor running around up here as well, who might be associated with you, which is, if that's the case, you're in very great hands. And I'll just try and get a little bit more about this up. Really, I don't even remember last year we had David Calhoun talking from the Heart Foundation about, as a cardiologist, about this. And what you're talking today is about the role of mental health and cardiovascular disease. So please all welcome Bella.
So I use this one?
You can use this clicker.
Okay.
No, this clicker.
Okay. Oh, this one. All right. Okay. So, is this?
This is
Forget this one.
yeah,
This one.
this is-
Okay. Perfect. Amazing. No, that's all right. Everyone's had struggles with the technical difficulties today. Okay, good afternoon, everyone. My name is Bella, and I will be discussing my master's project, which is exploring modifiable cardiovascular risk factors in people with serious mental illness who are engaged with community care in Australia. So I'm sure everyone here definitely has a working understanding of the term serious mental illness. However, considering the definition can be quite inconsistent in the literature, I thought I would just start us off by explaining the use of the term in my research. So serious mental illness, or SMI, is a group of diagnosable mental, emotional, and behavioral conditions which impair daily functioning. And for the purposes of this project, that's encompassing things like schizophrenia and bipolar disorder, as well as major depression and anxiety. It's a significant public health issue that is estimated to affect approximately 3.3% of Australian adults. So there is a well-established and substantial disparity in health outcomes between people with SMI and the general population. Currently, suffering from a serious mental illness can shorten a person's life expectancy by 14 to 23 years, and this is a mortality gap which has been steadily growing over time, and it is projected to further increase in the future. However, contrary to popular belief, as some of our previous speakers have already discussed today, the vast majority of these deaths are not primarily attributed to unnatural causes such as suicide. Actually, a very large component is due to chronic physical health conditions, such as cardiovascular and respiratory diseases, which are also occurring and being effectively managed long-term in the general population. However, research suggests that for people with SMI, they may account for up to 1/3 of avoidable deaths from these conditions. Now, we all know that regardless of mental health status, obviously cardiovascular disease is a leading cause of death globally. However, for people with serious mental illness, they are 6 times more likely to die from CVD than the general population, and are also more prone to developing CVD risk factors at an earlier age. CVD-related health problems are actually amongst the most common physical comorbidities for people with mental illness. So the ultimate goals of my project were really just to further explore that relationship between CVD and SMI, specifically in terms of cardiovascular risk and clinical management in the primary care setting.
And I did this using a research approach which involved a literature review, a descriptive statistical analysis, and qualitative interviews as well. So the first stage of my project was to conduct a literature review unpacking that complex relationship between CVD and SMI. And the major thing that emerged from that review process was the complex interplay of physical, psychological, social, and systemic factors which were contributing to excess CVD morbidity and mortality. These can kind of be thought of under two main categories. First is factors that are more centered on the patient's experience, so things like lifestyle behaviors or cardiometabolic side effects from psychotropic medications, among other things. These factors are all contributing to an overall increase in modifiable cardiovascular risk in this population. But then additionally, we also have healthcare system factors and especially disparities in access to healthcare, both in terms of diagnostic processes and then also initiation of treatment. And these failures of the healthcare system to adequately address and manage that increase in modifiable risk is also a strong contributor to the gap in premature mortality. This slide is just talking about some of the aspects of mental illness itself which can contribute to those patient-centered factors and sort of increase a person's cardiovascular risk. And it really underscores this notion, which is increasingly being supported by evidence, that cardiovascular risk and serious mental illness are directly proportional. So increased severity of mental illness correlates to increased likelihood of premature mortality. And that relationship is also bidirectional in the sense that physical health is, the physical health impacts of cardiovascular disease have an adverse effect on mental health recovery as well. And this really emphasizes how important it is for healthcare to consider both physical and mental health together instead of separately. However, unfortunately, what we see all too often instead is poor clinical management of cardiovascular health when we're looking at people with serious mental illness. And this occurs in two major areas that I've centered on in my literature review. The first is during prevention and risk factor intervention. So we see all too often insufficient screening of seriously mentally ill people for CVD and its associated risk factors. And that's both physical risk factors as well as lifestyle-related ones. And actually, one meta-analysis found that less than 50% of patients were receiving screenings for factors like cholesterol levels and glucose levels. This issue extends beyond screening risk factors to just addressing physical health in general, as a 2022 study found that only 1 in 5 healthcare consumers with serious mental illness had experienced a mental health professional inquiring about their physical health. One reason for this is fragmentation, which is basically when all of the different specialists that are involved in the care of a person with serious mental illness are not communicating with one another, and essentially the ball gets dropped regarding their physical health because everyone is assuming that the other team have got it. And another phenomenon referred to as diagnostic overshadowing, which is where complaints from people with serious mental illness about their physical health is dismissed or not taken seriously, or often attributed to being a symptom of mental illness rather than a symptom of an underlying health problem, physical health problem, also contributes to underreporting of physical health concerns. The other big issue surrounding the lack of sufficient long-term treatment methods being delivered for people with serious mental illness is the lack of consideration for lifestyle interventions and an over-reliance on psychotropic medications without any alternatives or strategies to address the associated side effects. And then in addition to that, we have an underprescription or being prescribed in lower quantities medications to target cardiovascular disease and its associated physical health conditions. And of course, as always, underlying these issues is a general issue with discrimination and stigma within the healthcare system when talking about issues that concern people with mental illness. So the major issues which emerged following that initial literature review were the increased modifiable risk and the poor clinical management of those risk factors. And this led me to constructing a new data set, which I used from data that I had obtained from the PharmaBridge randomized control trial, and constructing a new data set using that. So as I mentioned, the data from my project has been obtained from the PharmaBridge RCT. that was conducted over the last few years, in which a group of people with serious mental illness were given a 6-month tailored support service. And that was a tailored support service intervention that was led by community pharmacists and targeted medication adherence and physical comorbidity management, and compared the outcomes of this intervention with a group that had received standard care instead. And so the trial was conducted in community pharmacies across New South Wales, Victoria, and the ACT, in urban, rural, and remote areas of these states. For the purposes of my project, roughly 348 eligible participants completed baseline data collection prior to beginning the support service intervention. And so that my population combined the control group as well as the intervention group, because the baseline data was collected prior to any intervention being implemented. Participants consisted of healthcare consumers with serious mental illness from participating pharmacies and were recruited from trained pharmacy staff according to the selection criteria in the table. Baseline data was collected via an online questionnaire, and medication dispensing information was recorded from pharmacy software as well as in discussion with the pharmacist. So from that larger collection of de-identified baseline data, I then constructed a smaller data set by pulling out variables which related to cardiovascular risk. So you can see obviously there's demographic factors, but then also factors related to physical and lifestyle related risk, and also factors related to engagement with healthcare services. And using those, I performed a descriptive statistical analysis. So this first table presents some of the physical risk factors. It shows average results from the population of consumers with serious mental illness and compares them with averages from the general population according to the 2017-18 Australian National Health Survey. And we can see that consistently for all of the factors presented, the population of consumers with serious mental illness had higher averages compared to the general population. And not only that, but also a lot of the averages were notably in a range that would be considered at increased risk for cardiovascular disease and other physical health conditions. So just to give you an example to explain what I mean by that, if we talk about abdominal girth, typically it is considered that a measurement over 88 centimeters for women or 102 centimeters for men is associated with a substantially increased risk of chronic conditions. And we can see that in this population, the average result was 106.2 for men and women combined. The other thing I looked at was the prevalence of long-term physical health conditions, and we can see once again it's comparing the study population from Farmer Bridge with the general population. And we can see that once again, consumers with serious mental illness had higher percentages of all 4 health conditions presented here. Notably, the difference between the consumers with serious mental illness and the general population is smallest for cardiovascular disease itself. But when we look at these precursor conditions, the gap and the disparity grows significantly. And this is especially notable considering that the average age of the population from the Farmer Bridge study was around 47 years old. So quite young to be developing cardiovascular disease, but definitely the right age to be presenting these precursor long-term health conditions, such as diabetes, high blood pressure, and high cholesterol. And this really emphasizes the importance of early intervention work. In addition, I considered some lifestyle factors. So these are looking at the percentage of each population that met the government's recommendations for exercise and diet. So for physical activity, it's suggested to have 150 minutes per week or more of moderate to vigorous physical activity. And we can see that the general population had a much higher percentage achieving that compared to the Farmer Bridge population. Similarly, with fruit intake, we can see you're supposed to have 2 or more servings of fruit per day. And it's much closer, but still consumers with SMI had a lower percentage in comparison with the general population. But actually, when we look at vegetable intake, notably, consumers with SMI actually had a higher percentage of people in this group in comparison to the general population. However, unfortunately, the vegetable intake, regardless of mental health status, is very, very low, and we want to be improving that regardless of comparison between general and mental illness populations. I'll try and keep going quicker. So won't spend too much time on this, but 24.2% of the study population were consuming alcohol at moderate to high risk. and averaging 11.27 standard drinks per day amongst daily or almost daily drinkers, which is obviously a lot higher than the recommendation of no more than 2 standard drinks per day. And then with smoking, 41.8% smoking at moderate to high risk and median of 15 cigarettes per day amongst daily or almost daily smokers, when of course recommendations would ideally probably be 0 smoking, no cigarettes. Yeah, and so ultimately combining all of the risk factors that we looked at in this descriptive analysis, 92% of the population had 3 or more cardiovascular risk factors, and that's including physical and lifestyle-based, as well as things like age, etc. So looking at this graph, this is the proportion of mental health consumers that were receiving health services in the last 6 months from that Farmer Bridge population. And we can see that 3 of these are related to physical health. So we have a cardiovascular risk assessment, a hemoglobin measurement, and a participating in a health program. And so that can include things like assistance in quitting smoking or an exercise group, things like that. And in comparison, those 3 compared to having a mental health care plan are significantly lower in terms of percentage of that population that had received and engaged with those services. In terms of medication, 24.7% of the population had been prescribed cardiovascular medications with relevant indications. So that just means medications that treat cardiovascular system and also were prescribed for a cardiovascular related health problem. And then of those who had not been prescribed CVD-related medications, 43.2% had CVD-related long-term physical health conditions. So that's diabetes, hypertension, high cholesterol, etc. And 90.1% of that same group who had not been prescribed CVD-related medications had 3 or more CVD risk factors, which obviously does not imply that they all should have been on medications, because some of those risk factors are just lifestyle-based, but it is still interesting and an area that highlights for future research in more depth. So following from that, I decided to perform some qualitative interviews just to provide some more context. And I won't spend too much time talking on this because I'm still in the analysis stage and I know we have to wrap it up. So I did some interviews, 15 to 30 minutes, peer support workers. It was very interesting. Thank you for your time.
Thanks, Stacey. Got time for one real quick question.
Everyone wants a coffee. Let's go.
Once again, I just have to say this is just fantastic. All of these people are doing their high degrees, the last 3 presenters, and wow, and you've sort of epitomised the other 2. So let's all thank Bella and also all of the presenters. Just in terms of some of the segues, we've got a short 2-minute break, time for a couple of stops. But then Richard Osborne, who was on the panel presenting, and wow, isn't he got a bundle of energy and strong views? I'm really looking forward to that. Also tomorrow, in terms of the segues in terms of cardiovascular disease, Chris White, who's with Mental Health Trust in the UK, was with Breathing. I saw that report there, and he's talking about his experiences of a quadruple bypass and the etiology of that 35 years before, of 35 years of medical. I don't want to lose thunder. He's talking about his journey, which is such a typical journey, which you really described, Bella. So once again, can we all thank